Okay, everybody, I'm super excited about today's episode, which I feel like is how I begin all of my episodes saying that. I have on my husband Vito with us again today, and then we have on Tiffany Alblinger, and she is a midwife. She works in California. She's a home birth midwife. And I've had home birth midwives on here before, but I've never had Vito be a participant in it. Because as you guys know, we put out an episode a couple weeks ago talking about how we really want another baby. And I really want a home birth. He's very hesitant. And what?
You don't really want a home birth. You said the only way I'm having a fourth is if it's at home.
True.
So I have a lot of
So,
growing to do, I guess you could call it.
well, but also I'm excited for this conversation because as a birth doula, I always, especially with like repeat clients, I have some repeat clients, and most of the time they want a different experience because we've had to advocate and fight so hard for certain things in the hospital. And so I'm like, why don't we consider birthing center, home birth, and a huge, I would say a majority of the time it is the partner. They're like, well, he's really not comfortable with it. Like they're very, very more hesitant on it. In my experience, like as a doula, I'd say a lot of times that's kind of like they had to get them on board to even hire a doula in the first place. So to jump to doing home birth is like a huge leap. So I'd like to touch on that, but I'd love for you just to kind of like do a little introduction to yourself. How did you get into this work? And then we'll dive right in.
Yeah, thanks guys for having me. I was just saying before we even started recording how important this topic is to me because the majority of dads are in the same place that Vito's at. Like, okay, whoa, hold on. You've had me all along on this whole natural birth thing. I got that, but like doing it at home, that I feel like we just, leaped ahead 12 steps. I don't know if I'm there quite yet. And so we work with a lot of women, of course, in our home birth practice. My partner, Kelley Pappas, and we run a totally independent, individually tailored home birth practice. So that's all we do in San Diego is just do home births with our clients. And I started out as a doula and was really passionate about the family experience of birth. And I was doing that for several years before I even went to my first home birth. And the first home birth I saw or participated in or supported, it was just like a huge light bulb moment went off because even though it was a lot of like sensory overload for me, just trying to figure out how does this thing work? What is the midwife doing? And what are we supposed to do? And like all those pieces. The result was a family that was easily afforded everything on their birth plan. There was no fighting, there was no negotiating, there was no trying to work with the system or, there was none of that. It was just copy and paste, getting exactly what you wanted out of the experience. And granted, that's not always the case at home birth. There's birth disappointment in all birth settings. But for me, watching that whole event transpire and seeing how it was just so completely different than what the hospital had to offer. At that point, I had done dozens and dozens of hospital births, and I thought we were lucky if the mom had come out of her birth experience feeling like, okay, that wasn't so bad.
Mm-hmm.
There was parts of that I really liked. Or if it went smoothly, or if she had unmedicated birth, it was just like, whoa, we hit the jackpot. That was so cool. We all had to work so hard. I'm so glad that we were all on board with that, versus seeing it done at home. So I just became really fascinated with home birth at that point and went straight off to midwifery school. I was like, I need to participate in this, the way that birth is done in this way. And so I supported myself financially. I was paying for midwifery school by continuing to doula, and eventually had to stop doing hospital births, and figure out other financial means of getting the rest of my school paid for because it was so difficult for me to take the knowledge I was learning and this way of doing birth and transport, like just once you know more information, and participating in those types of birth experiences with women, the whole entire birth, I was just like, that's not necessary. That's not fair. That's not what you said you were going to do. That's, like to the system, to the medical system. I just felt so angry that this woman who was doing such a great job at progressing or advocating for herself, or had so carefully picked the provider and the location to give herself the best chance possible, was still being abused and railroaded and had so many pieces taken out of what I felt like should have been in her control. So that's really what like propelled me and made me a huge advocate of home birth. And I don't think that it's right for everybody. I don't think that everybody should have a home birth, but I do think that considering that our country has like a 2% home birth rate, there's actually probably more than 90% of women who are candidates for home birth. And so I am really passionate about flipping those statistics. I think that we could do really well. I don't think that 90% of women need to have home births, but I think that we could have 4 or 6 or 10% of women having home births in this country. And to see that number climb, to see that number steadily rise, because when we assess the risk and we assess the appropriate setting for that risk, it's really reasonable and it's really appropriate for low risk women who want to give birth at home to have the advantage of being able to do that.
So you had said that that a lot of women are good candidates for home birth. What does that mean?
Yeah, so we have a screening process. All home birth midwives have some kind of screening process, but in our practice and abiding by California law where we practice, we have a certain set of criteria that we have to be able to validate with the candidates that we're screening. And so that's a part of the process. A really cool part of beginning to go down the road of considering home birth midwifery is a huge step in that is meeting with actual home birth midwives and having an interview process. And it kind of goes both ways. So during that process, the potential client has the chance to ask questions. We have a chance to ask them questions and figure out kind of their motivation. And if we're all kind of matched up, and can we work together? Do we have the same goals, kind of a thing? And we're also doing risk assessment in that case. And so women who are free of maternal disease, essentially, or free of any prematernal disease. So we only take care of women who have excellent bills of health, who, don't have diabetes, who don't have hypertension, who don't have some other, medical piece going on with them. So there's a screening process. We don't take care of women with severe asthma. We don't take care of women with heart defects. We don't, there's lots of pieces where we end up with, even though it's the majority of the population, we end up with a client at home who's their candidacy, a huge part of their candidacy is their desire, of course, and them being very medically low risk.
Okay. So, and it sounds like each state kind of has different criteria for what they consider a good candidate for low risk. Okay.
Yeah, because there's some midwives who say, well, your risk status goes up if you're over 35. There's some midwives who say, well, your risk status goes up if you have a high BMI. Your risk status goes up if it's your 5th baby or more. So those aren't constraints that we put in our practice. We're not that tight, but the concept of risk can be fairly subjective throughout each midwifery practice. So that's an important thing for women to understand. Well, and families just in general. When you choose home birth midwifery, you kind of feel like, oh, wow, okay, we did it. We came to this conclusion. We're having our baby at home. We need to have a midwife. And you kind of have this idea like that we're all the same. And so a lot of women go through the process of having their home birth midwife. And it's not until after the scenario of birth that they sometimes look back and start to consider some of the events that interplayed in their scenario,
Mm,
and feel like, wait a second, I thought midwives were all supposed to be supportive of this, or I thought that my midwife had displayed herself as a provider who was all totally okay with this, but in the end, she actually wasn't.
yeah,
So that screening process is really important for midwives, of course, to have a low risk patient, but it's really important for the potential client and the consumer to understand that all midwives don't practice the same. We don't all have the same
sure,
criteria.
sure.
I was gonna say, but also like since you're in California, like by law, like you're technically not supposed to do certain things that are maybe allowed in other states.
Oh, totally.
I know
Yes.
in Illinois we have some similar restriction, I think, to California. Like, I think technically you're like not supposed to really do breech birth here. You were supposed to risk out at a certain point with twins. You're not supposed to go past 42 weeks. There's certain things that the state of Illinois puts on you, which I find so unfortunate because it leaves women feeling without options again. Like you've done so much research, you vetted this choice, like this midwife, and you're like, okay, cool. Like I finally get to have the birth I want. And then the state is like, no, because you could lose your license or whatever. So I've always found that like, I don't know, frustrating. Vito knows, I've already told him like if I'm breech for some reason, Wisconsin's so close. I'm like, we're driving over the border. It's fine.
So you mentioned that like motivation matters. What's like a couple who came to you with a motivation that you were like, I'm not taking on this couple?
Okay, so COVID was a great example of
Mm,
like a mass exodus from the hospital towards other options. And some of those
Mm,
other options were home birth. And so we consulted with lots of families that just because you don't want to have a hospital birth or there's something that you don't like about how the hospital does birth, that doesn't automatically translate into you are ready to take on the responsibility of participating in a home birth. And that's really the biggest difference on the
mm,
consumer side is the responsibility. And I think that's the biggest piece that couples and families can kind of get hung up on is like, no, I don't want that responsibility. I was so much more comfortable when my doctor had that responsibility,
mm.
when the facility had that responsibility.
What kind of responsibility?
Well, so like you're responsible for taking on the reshifting of risk, right? So in a hospital, you have the risk that's associated with all the intervention. So you're more likely to have an induction, you're more likely to have an interventive birth, you're more likely to have birth trauma, you're more likely to have a cesarean. And you trade that risk, that potential risk, for most of all of those things are not included at home birth. So you can almost say, almost for certain, you are not going to encounter those risks or those risks to the highest degree at
Mm,
home. But what you do change that for is a really small percentage of potential emergencies that can occur. It's a little bit less than 1%. It's like 0.91 or 0.87 or something like that. That you experience an emergency during your labor or birth that it would have been really, really critical to have had an OR down the hallway or a NICU team ready to, intubate and medicate your baby or something like that. So we talk about those risks really frankly,
mm,
because even though it's a really small percentage, it doesn't mean that hospital or it doesn't mean that home birth is completely risk free. It's just a different exchange. It's a
yeah,
different,
the
it's a
trade-off.
different, yeah, it's a different trade-off. And it works really well most of the time. And we talked about screening prenatally, and we talked about screening. Well, we talked about screening before we even start working with women, but then we're screening them continuously throughout their entire pregnancy. But we're also screening in labor. And so we're always looking for what is that judgment call where we transfer in labor in order to avoid that little bit less than 1% emergency
Sure.
statistic. So
And there are signs that you can look out for that would like what is that emergency you're talking about? What is that 0.89% emergency?
Yeah, it can be a lot of things. Some things that would be like really critical would be like pulmonary embolism, or
That means nothing to me. What does that mean?
it means you get a blood clot, or not a blood clot, but you get a like part of your amniotic fluid ends up getting transferred into your lung space and kind of like creates a total
Oh,
physical
geez.
shock. Yeah, there, and it's extremely rare, but
Hmm.
it is a risk of birth. It is a
Mhm.
maternal
Hmm.
risk.
Hmm.
Um, the chance of uterine rupture, for example, especially in women who have scar tissue on their uterus, they're at an increased risk for that. That would be something that generally needs emergent attention. Babies
This,
who,
sorry, this might be a dumb question, but is there a way to know if you have scar tissue on
yeah,
your, like
usually,
beforehand? Yeah.
yep,
Yeah, it'd
usually,
be from usually
Because
like a previous C-section or like a myomectomy, like if they remove fibroids or something like that. Like you would know if the scar tissue is usually from like surgery. It's not like just randomly you have scar tissue without any
okay.
intervention. Yeah.
Because my sister-in-law actually, she had the uterine rupture. So she was going for a VBAC.
yeah,
Can I talk about this? And
Oh, it's on her.
yeah, so basically, yeah, they were like it wasn't going that well, so it ended up in C-section from what I remember while they were doing the cesarean, her uterus ruptured. And I was like, holy cow, it was really scary,
Yeah, she ended up needing like blood
Yeah,
transfusions.
it was really scary. And it always made me think like, well, how do you even know if something's wrong? Like it obviously makes sense if there's past surgeries or something, you know,
Yeah, but even like with a uterine rupture, it could be happening and you could have no idea that it's happening. Like you could be in
that's my
labor.
fear.
Yeah, I mean that's a realistic thing. I mean, like she said, like it's rare, especially like in low risk, no previous scar. But I mean, birth in general has risk.
Yeah,
And
right.
if we told women like every single terrible thing that could potentially happen to them in birth, they would never give birth. But over 99% of the time, everything's fine.
Yeah, sure.
Um,
So before we get ahead of ourselves, I just want to let you know kind of where I come from.
yeah,
So Liz has a very big family from all over the country, and they are very much like home births is normal to her. And home births was something I saw in movies as like a joke, you know? Like this is not my world. When Liz told me she was a doula, I had no idea what that meant. When we did the midwife practice for our first daughter, I was like, what is a midwife? Like this is all new for me. So when she's brought me to a place, it's only been 4 years where I'm like, what? What's a doula to, oh, now we're having a home birth. So this is, for me, it's extremely difficult to come around to. And I think that's something that doesn't like, would you agree that most of the time it's the partner who isn't comfortable with the
yes.
home birth?
Yeah, I've had a couple of really weird scenarios where the dad wants it so much more than the mom, and that never goes. That never
That's
goes right.
interesting.
But it's
Yeah.
really uncommon. Yeah, and we're used to dads who are a little skeptic, a little bit shy to, get right on board, asking a lot of questions, trying to figure out
Mhm.
safety and finances, honestly. I mean,
Yeah.
that's the role of
Right.
the husband and partner, is to keep everybody safe and to keep everyone on track with all the things. And so
Mhm.
it's really normal for the guy to say, oh, hold on, I'm not getting like swept away with the romantic piece of this quite
Right.
yet. So
Right.
let's sort out the practical pieces of it.
For
Um,
sure.
and so that's okay. That's really okay to acknowledge that you guys are coming from two different places and having different approaches and different motives, and the desire to want those to mesh together can
Mhm.
sometimes just take a little bit of time and communication.
Yeah.
And
Well,
yeah,
so the reason why I bring it up is because like I'm going to ask you a lot of what seem to be dumb questions. So
no, there's no
for
such thing as one
for
question.
for example, like a midwife. like how long does it, you said you were a doula and then you went through midwife school. How long is the midwifery school? What are you learning? What are you actually coming out with? Like what is a midwife compared to an OB or compared to people always ask me, I'm like, oh, Liz is a doula. She's like, oh, she delivers babies. I'm like, no, that's a midwife. And they're like, well, what's a midwife? And I'm like, I don't know really. Like I do, but I'm like, I don't know what their credentials are or like how much schooling they have or like can they administer? I mean, I've learned more because we've had three now with midwives, but can you just explain to me like what your schooling looked like and kind of how long it took and what you come out of it with?
Yeah, absolutely. I mean, I tell people I'm a midwife all the time, and they're like, "Oh, that's so cute. Oh, so you like are with women at the hospital or something?" And I'm like, "No, that's a doula. I'm a primary care provider. So you would hire a doula as your companion, as your advocate, as your cheerleader. You would hire a midwife in place or alongside a doctor. So um, midwives have all different ways in the United States of achieving professional credentials. Some midwives are nurses first and then go on to get a master's in midwifery, and that's primarily under the medical model. And those most of those are called certified nurse midwives. They work in hospitals, sometimes in birth centers, and they can do home birth too, but they usually don't. And then there's the Certified Professional Midwife, and that is a nationwide designation by NARM, which is the National American Registry of Midwives. And that is the national governing body that regulates midwifery in the United States. And there's a couple of different pathways to that, and those credentials are Certified Professional Midwife. And those midwives usually work more in birth centers, more in home birth, and they're trained under the midwifery model. So it's important to recognize the difference between the medical model and the midwifery model because philosophically they're very, very different. And so
Okay.
even though a midwife might be a midwife, if she works in the medical model of care, which is all hospitals and some birth centers, she is going to be obligated by her employer, essentially, to provide a style of care that is more aligned with the medical model.
Right.
The medical model kind of like pathologizes pregnancy and birth. It's looking for disease processes. It's expecting those to go, expecting something to go wrong, expecting something to come up. Um, it really views the provider as the important decision maker in the process. So your doctor knows best, or whatever provider in the medical model, your midwife or your nurse practitioner, they know best. They went to school, they have the expertise, they have the information. So we really need to be following along with their guidelines and their
Hmm.
expertise. And it can just undermine the really natural and normal process of birth. In the
Hmm.
midwifery model, we are constantly working to put the woman at the center and put the family at the center of the experience. We don't think that we're the most important ones in the equation. We're looking just to constantly elevate, equip, encourage,
Hmm.
the mom and the family to make decisions that feel right for them, giving them all the information, giving them our own experience, giving them our own expertise, but really allowing the woman to take the driver's seat and allow her to make the decisions. And then we support that, even if we don't agree with them.
Hmm.
Um, Even if it's not what we would do, a really good midwife or a really good care provider in general is going to provide informed consent and then stick to the wishes of the mother. And then as midwives working with low risk moms in a midwifery model of care, we are not expecting things to go wrong. We're expecting things to go right.
Hmm.
We're expecting it to be a relatively smooth process. We don't rely on technology, but we can use technology if we need to, but we don't rely on it in order to tell us all the information that we need to know.
Sure.
And we're looking for signs that that everything's going right, because we believe that when we let the process of pregnancy and birth with a little bit of scaffolding, a little bit of good support and preventative care, that the outcomes are really good that way. We don't feel
Yeah.
like we need to intervene. So I think that's an important distinction, because you can have midwives who practice more medical, you can have physicians that practice, a little bit more aligned with the midwifery model, and
Mhm.
sometimes labeling the provider doesn't really help women figure out if they're in the right location with the right provider. Sometimes really diving a little bit more into their philosophy is
Mhm.
important. But so the different ways of getting to um, the the designation, the credentials, the profession, it just looks like various forms of schooling, which is the didactic portion. I did in my program, I did 37 consecutive months. So it was kind of like a 4-year program, but with no breaks.
Mhm.
And then I had a certain amount of experiences I had to have. So I went under apprenticeship for like 4 years
Mhm.
and did a certain amount of births under an experienced midwife and multiple different practices, and started out observing and then assisting and then practicing being the primary care provider with supervision.
Sure.
So it's a fairly um, robust and vetted and solid way of
Yeah.
gaining experience and professionalism. So in California, because we have licensing in this state, I don't know if Illinois has licensing or not.
The law just changed.
Okay.
So CPMs weren't really allowed to practice here
Yeah.
until this last year, legally.
Amazing. Yeah.
So I agree with you. I think for me personally, from what I know and my experiences and learning and hearing the nonstop stories that Liz tells me, and also like I grew up with 4 girl cousins that were my age, so I know way more about the female experience than I should probably. Um, and I do think that the midwifery care model that you're talking about, not the medical, but the midwifery care model, I do think it is the best. And I think Sarah has been amazing. But even when, like you were saying, how you worked under a midwife in your, I don't know, let's call it apprenticeship part of your education, we had the same thing with Maria.
Mhm.
I mean, we had someone who was learning next to Sarah who was helping with our second.
Sarah was our midwife for all three
Yeah.
of our births.
So I think it's the best personally. What are you learning in those 36 months? Because from everything that you said, it sounds like, and I agree that birth is a very natural thing and people should just leave it alone. And that's basically what you were saying, right? You're letting the mom make informed decisions, and then you'll support her, even if the thing that kind of I get confused, like even if you don't agree with it, because in my head I'm like, well, you did the schooling, why would you not be like, hey, this is the right decision to lower risk or whatever? So I guess like what's the main part of the education? Like anatomy, biology, well, what is it?
Yeah, those are great questions. It's all of those things. So we're learning about normal physiology, we're learning about holistic tools, we're learning about complications, we're learning about taking care of women outside of pregnancy, we're learning about normal birth, we're learning about certain pseudo complications that can come up and how to normalize those. Um, our school was like had these monthly modules. So like 1 month we would learn all about shoulder dystocia. The next month we'd learn all about hemorrhage. The month after that we'd learn all about herbology. The month after that we learn all about preeclampsia. And so we just had this large breadth of didactic learning that was
Okay.
midwifery text, formal lecture, writing papers, doing projects, all that kind of thing to like get it in. None of that made sense until I was actually doing it in real life, like
Of
most things,
course.
right?
Of
Yeah.
course, yeah.
So, the thing about midwifery care that some people look at as a deficit, but I think it is the coolest asset ever, is that a doctor is specializing in disease and complication. An OB is an expert in surgery. I mean, obstetricians are surgeons.
Yeah.
That's their greatest tool. Um, Most of them don't have any training or education on nutrition or counseling women on preventing some of the complications. Um, lots of crazy things that we could go into. But midwifery is focused on normal. So we learn normal really, really, really well. And we learn to recognize when things aren't normal just because we know normal so well. So I
Mhm.
don't need to be the expert in this little complication over here. I don't need to fully understand exactly how to treat this thing that just needs higher level care. Like we're going to transfer no matter what if that thing is like pinging out of normal. But we know normal. And so we get to experience um, and create and affirm during the process
Mhm.
how normal most of it is. And when something is outside of normal, then we can go, oh, wait a second, that's not quite right. Let's look into that some more. And that
Okay.
can be anything from like your iron levels are low, or your birth is taking a really long time. Is this, something that's going on? Is there something more that we can do? Or your newborn is transitioning really slowly. I don't know exactly why they're having respiratory distress, but I know that it's not safe for us to stay at home with them anymore. So
Mhm.
there's such a variety of what can be abnormal, and that is a huge part of what we're learning as midwives. And I think that that's really cool, um, because I don't need to be the expert in complications. I just need to recognize when things aren't normal anymore. And so that takes a significant amount of pressure off of the provider to be the know-it-all, kind of.
Mhm. Yeah, yeah, yeah.
And I have no problem saying, oh, you know who the expert in this complication is? The
Yeah.
dude in L&D down the street. Like
Yeah,
now
yeah.
we're gonna go there.
Yeah.
And so that I think that's what midwives bring to the table that is quite an asset.
I love that you say that
100%.
like midwives know what normal is because I feel like most OBs don't. And I was texting him the other day, like I was at my daughter's ballet class and like these moms were just talking about all the introductions they're scheduled, oh, I scheduled inductions with my last ones at 39 weeks, now this one, but there's like an IV fluid shortage, so they say I might not be able to get it till later and like just all this stuff. And the other one had inductions, and I'm just like sitting there like listening, and I'm like, oh my gosh, because like one of the births that I went to, it was my first time at a different hospital, and the nurses were like, oh my gosh, this is so much fun. Like, we never get to see unmedicated birth. And I was like, really? They're like, no, honestly, most of them are inductions. And I'm like, what? Like, and it's just, I didn't realize that was like a few years ago, like how the induction rate is just like, it's not accurately portrayed at all. Cause I think they say the induction rate is like 30 something percent. It's way more than that. Um, because pretty much every single person that I talk to has an induction. So, but I just love that you say that like you guys know like what normal looks like, because in the hospital setting, they really don't ever get to see that. Um,
I have questions.
yeah, I know. I know you do. I bet your question is because if she's like, okay, well, we know like when to transfer, it's like, well, what can you do at home?
No, no. So my question is how many or what percentage of outside of normal abnormalities are are identified before the actual emergency?
Most of them.
Okay.
Yep. Our job is to continually screen. And we kind of have like this way of assessing it. We like to just create this little circle in our minds as like, this is normal. Everything that happens, there's so much that can happen inside of normal, but maybe one little thing can ping outside of normal. And it's like, oh, Well, your water broke and now your contractions haven't started for over 48 hours. So, I wonder what's going on there. Oh, now you're starting to actually have contractions, but your baby's heart rate is a little bit higher than usual. There's another ping outside of
Mhm.
there. And then, oh, you're exhausted and we're having a really hard time getting your contraction pattern regular and you're not making very much progress. It's kind of like a third thing that pings outside of normal.
Yeah.
Could be. I'm making up like a total scenario here. But we kind of have this like 3 ping rule where we're like, that's a little bit normal, but not abnormal, but not necessarily a problem.
Mhm.
That's starting to compile a bit of a risk
Yeah.
picture for you, but no, it's not emergent. We don't absolutely have to like take you to the hospital right now just because these 2 things are going on. Oh, but this third thing, and we didn't resolve the first 2 quite yet, which maybe we've been working, for a whole day on trying to bring some of these other pieces into normal. Then we start to have the conversation of like, okay, there's a lot that's kind of pinging outside of normal. You are not experiencing an emergency right now. We don't foresee you necessarily the way that things are going to have you, encounter an emergency, but
Mhm.
you are starting to get far enough outside of normal that now we need to start having the conversation that this could be something that ends up with, needing more hands on
Yeah.
board, needing a higher
And
level of care. So it's a
and
continuous conversation. It's a
yeah.
continuous assessment and conversation.
Yeah. And you're continually checking the baby as well, correct?
Yep.
Because like in my head, I'm like, this is everything you were saying. I'm like, we're wasting time. Like in my head, I'm like, the cord's wrapped around the baby's head and it's just gonna come out. Because my neighbor growing up, the doc that was at a hospital and the doctor did something. We never got the full story, but the doctor did something. He messed up and the child ended up with like not enough oxygen to the brain, and the
Would kill
child
them.
grew up, I mean, into their 40s and stuff, just like basically blind and kind of just abnormal. I don't like to use the word, very sweet person, but
They had to take care of her.
they had to take care of her,
She was in
right?
her 40s, still living at home. They needed to take care of her, and it was all from her
Yeah.
birth.
So when
Yeah.
you talk about things, when Liz talks about things in my head, I'm like, because you can't see the baby, right? And there's indicators, obviously, like I need to learn how to trust more clearly. But it, like you said, it is my job to provide and to protect, and I am completely useless in this situation. And it is very vulnerable for the husband, the father, to like have no control over anything, no matter how educated you are, no matter what. Like you really are useless. So we're just trusting our wives and the provider, and it's difficult to, because I've known so many experiences where like things have gone not perfect. I'm like, how do you know like 24 hours after the, okay, this, that, like obviously okay, this is an emergency indicator. This, if this pings, like we're going now. So obviously you guys have that expertise in learning what normal is, which makes a lot of sense. And then I was thinking about our other births where our midwives were constantly taking notes. Is that something you do?
Yeah.
Like
It's
throughout
called
the
charting.
whole, yeah, I mean, they were taking quite a bit, I thought, which I liked. Because then for me, I'm like, okay, like
Yeah. It's doing
they're
something.
actually like they're not just, because a lot of times they're sitting there like not really talking, not really doing anything. I'm like, Sarah, what's, I'm like looking at her, I'm like, she's not nervous, I'm not nervous, sort of thing.
Right.
Um,
And the whole like not doing anything is like part of the process. Like most midwives have been taught to observe. Like that's what you're doing. You're just observing, you're watching, and just by watching, you can kind of tell where somebody's at. And you don't have to do a cervical exam, you don't have to intervene, you don't have to do other things. So you're sitting there, you're being with them, you're observing, and then
I've gotten pretty good at observing,
yeah.
because Liz is one that like refuses to go when it's time to go. She'll be like, no, 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 I'm good.
Well,
I
I
can
just want
talk
to tell
through
her
my
though, because she knows that
contractions.
we've had midwives, but she knows we haven't had a home birth yet. So our first one was in a hospital with our midwife, and then our midwife left to open up a birthing center. So the last two were at a birthing center. And he was at first kind of like with the birthing center, but he knew our midwife and got on board pretty easily. And after being at the birthing center, you have said you would never want to birth in a hospital again.
Yeah.
Just the difference of everything,
Everything.
just the
Yeah.
environment. You get to go home, like you have your baby, you get to leave. It's, just it's so, so nice. So you're probably like a step ahead in that way than maybe other people who are like, no birth, like birthing center scary. This is scary, like you're on board with the birthing center. Now it's
I
just
was
getting
more,
you that
I
next
was,
step to home.
so I'm more on board with people, right? Like I trusted Sarah. So,
But
and
she's leaving the birthing
no,
center
I get
now,
it. I get it.
so
I get it. So let's go with our last child. He came out stunned, which I guess happens to 10% of babies. This was something I've never heard of. It never came up in conversation. I ask every question. So he came out just like lifeless. I mean, like a rag doll, not breathing, purple, nothing was happening. And I like Liz didn't see it, and I was watching it, and I was like, she's like, oh my God, it's a boy. And in my head, I'm like, that baby's dead. Like, and so regardless, they had like an oxygen tank and another tank that just like shot air out with something that you put over the baby's, I don't know the technical terms, but you put it over the baby's mouth and it like basically resuscitated him or got him to start breathing. What, as a home birth midwife, what are you bringing? And like in that scenario, can you do the same thing? Or like, what is that whole, you're trained in that? Like, explain what you would do in that situation. Or if maybe you've had that at a home birth.
Yeah, so I think one of the things that is a misconception of home birth and birth center is that it feels like the birth center is like so equipped and so professional and so put together. And it's like this really comfortable middle ground because I'm not going all the way to the hospital, but I'm going to like someone else's house, basically, right? I'm going
Mm,
to this other like nice room with this cute tub, and my midwife's meeting me there, and like she has her way of accessing all of her equipment and stuff. But there is nothing, and I'm just saying here in California, but it goes pretty much for across the United States. There is nothing that birth center is equipped with that I don't carry with me to
you
home
bring
birth.
oxygen tanks with you? Okay.
Yeah, there is nothing. And we worked in a birth center for a while here, and they had absolutely nothing that we don't carry
You
with
bring
us.
Pitocin?
yeah.
I don't say yeah.
I told you.
The one midwife because our first was like in the heart of COVID. So we were like, we're gonna have it at home because they were talking about not letting the husbands in the room. So I'm like, there's no way you're giving birth and I'm not there. There's no way. I was like, I'd rather have it at home. Like that's how I was. And we interviewed this lady and I was like, no, I'm not, just didn't get a good vibe
The
from it.
interview was fine,
So
but
you said you didn't feel comfortable.
we just decided not to go that way. It wasn't like,
Yeah. No, I just didn't like the whole situation. But can you give me like a quick, I don't want to like not everything, but like what's a quick list of like your most impactful tools that you bring or like the most like holy crap, not holy crap, but okay, well, this is something we need to use right now. What are you bringing to the house?
Yeah, I mean, we bring everything. We try to do it as compact as possible because we're dragging our bags in and we're unpacking them while we're setting up the space while the mom's continuing to labor. So we have a bag of like emergency things. If the birth's going really quickly, then we just grab this one bag that's like the most likely things that we'll need really quick as the baby's being born. But otherwise, we usually have quite a few minutes where we can unpack and set up our, stations and stuff. And so I don't know, just the things that we bring, well, and then that's the thing that we have to continually remind ourselves we never use this equipment. We
Hmm.
never use it, but we need it in case
Hmm.
something happens, and we don't always know when that's going to be, right? So we're always unpacking it, we're always getting it ready, we're always making sure that all of our equipment is in dates and that our bags are stocked and all that, because that's the whole point of having a midwife. I think if you just wanted to have just a birth at home and you were expecting everything to go well and you were convinced that that was going to be the case for you, then you can just have a baby by yourself at home, right? I mean,
Right.
it's
Right.
probably going to go fine. The whole point of having a skilled provider there is in case something goes a little bit sideways, you have somebody who knows how to bring things back into normal. So the three most common complications that happen just across the board in all kinds of birth, but we're especially equipped to handle them at home because we can use tools to bring things back into normal. So just because women are experiencing one of these complications, it doesn't mean that we're like calling 911 and getting transport ready and saying, sorry, everything is just a mess. I know you wanted this to end up better.
Hmm.
But we're usually just using as little amount of tools that we have in order to bring things back into normal. And we've been very successful with that in the past. We have shoulder dystocia, which is where one or both shoulders get stuck, of the baby get stuck on some part of the mom's pelvis. And that's really just about pelvimetry and the baby's rotation maneuvers and helping them to get their shoulders compressed into a smaller diameter and shifted a little bit in the pelvis so that they can come out. And so there's lots of ways that we're trained to handle that. And another one is hemorrhage. That's probably the number one complication just worldwide for women giving birth, hemorrhage, and blood loss during birth, but mostly postpartum. And in California, we're licensed. I mean, it's the great part about working licensed, except for like free birthers would say, no, the license is what actually destroys women's autonomy and makes us, have to make decisions based off of state laws and stuff like that. So,
Hmm.
that's controversial, but I like working in a state where I can use my license to have the meds that I want to carry in case there is an emergency. And we have 4 of those. We have 4 pharmaceutical medications that we can use for women
Hmm.
if they're bleeding too much, even though we hardly ever use them. And then neonatal resuscitation. So similar to what you experience with your son, a baby comes out, they need a little bit of help transitioning. Usually it truly is just a little bit of help. But if something's going on and we missed all the signs, or there were no signs and this baby just needs a whole lot of help, or this woman is not stopping bleeding with all the tools that we have on board, then we activate EMS and we continue working with the tools that we have until we can get help to arrive there. And so you
Hmm.
mentioned with neonatal resuscitation, we have oxygen, we have PPV, which is just positive pressure ventilation, helping that baby get their lungs
Sure.
um, inflated. We have a way of measuring oxygenation in the baby's blood. We have lots of assessment tools and
Yeah.
equipment like that in order to at least provide the first responder type care until somebody else can arrive to get baby or mom to higher level care. But like I said, the majority of the time, huge majority of the time, we intervene a little bit with a complication like that, and then we're able to resume staying at home, things maintaining a normal pace, and just as a team and as a family recovering from that and having it's more of like a holistic experience. It's like, wow, that was
Hmm.
really scary. How did you feel about that? That was really hard, huh?
Yeah.
Okay. And yeah, the baby, that was a huge experience for them too. And that's something we're going to continue to talk about over the next several months as you process that. But so good that we got to stay home and keep things normal and stabilize you at home so that an emergency transfer was not also a part of the story. But we talk about that with our clients all the time, and it's a huge piece of how we screen clients.
Mm,
We that if we don't have people sitting in our office interviewing us to be their midwives, and they're not asking us questions about safety or our training or the equipment we bring or how we handle emergencies or our philosophy around intervening, then we're like, this is a red flag. You have not considered the risks. You are not really properly taking responsibility for those things. If something bad happens, that we have to like walk through together as a team, that client could be a risk for us too, right?
yeah, for
So
sure.
the compatibility of the midwife and the client and the relational piece is huge. It's a huge part, and that continuity of care, seeing the same provider throughout as many months of pregnancy as possible and spending those long appointment times, getting to know each other, building rapport, learning each other's communication styles, lots of opportunity to ask questions, lots of opportunity to talk about things that you're afraid of or need more information about, learning just how you learn, right? How
Mm,
you like to be given information, is a huge part of what keeps women safe in the birth event itself. Because, like you said, your midwife, Sarah, you trust her.
mm, yeah.
And that happened because of the relationship that you guys got to build together. And so it would be so much easier for you to have a complication with her than it
Mm,
would be for some other lady that you never met before, right?
yeah.
Well, you've even said you're like, if Sarah would do her home birth, you would do it.
Well, I trust her obviously because we've been through a lot together. Because even with our first, you had a lip.
Oh, my first birth. Yeah. I mean, I had a cervical lip, which happens. But I was in labor for like a super long time.
So wait, a lip, right? Like if you didn't get the epidural, no,
Yeah, I got an epidural.
right? If you didn't get that, you still would have delivered fine.
I had the cervical lip before I had the
No,
epidural.
I know. But did the epidural do anything to that, or did you just push right through it?
I mean, a lot of times, do you want to talk about like a cervical lip?
Sure.
Yeah,
Yeah, I
please.
mean, it's a normal variation of cervical progression. So it just means that maybe the whole rest of the cervix is completely dilated, except for maybe like a half or a third of it is still kind of hanging out on some part of the baby's head. And it can be like a very persistent piece that's just taking a really long time to soften and continue to open and move back. But it is almost a part of every single cervical progression in labor. It's just a matter of, are we catching it? Are we
Mhm.
pathologizing it?
Right.
Um, Women who get a lot of cervical exams in labor or just get a cervical exam while that process is happening, um, then it ends up being something that's diagnosed, and it can cause problems for progression. Like, for example, we don't give a lot of cervical exams. We actually advocate for almost none. But if women really want one, then we're like, absolutely, that's part of what we're here for, is to help you with this process. And if that information is useful to you, great. But it's really common for us to be all the way to the pushing part with women without having had a cervical exam. But if she's pushing really hard and the baby's not coming out at all, and she's saying stuff like, I think he's stuck, I just can't get him to move, nothing feels like it's changing, then we might think like, oh, maybe part of the cervix is still
Mm,
in the way. And like you said, Vito, you can work through that. You can just push through that. And that's the majority of cervical lips, because it's a normal variation and it's happening. And if we don't know that it's happening, but we're just working with the sensations and the pattern of the labor, most moms are just going to push through it.
yeah.
And
Yeah.
Because in that
yeah,
in that birth too, because she was, let's call it stuck. I don't know.
So Jovi
But she
was,
wasn't recovering.
well, she was asynclitic. So my water ruptured first, like really early on at home. I was having mild contractions, went in, I think I was in labor for like 19 hours. But they thought that I was like in transition, and I had asked to like get exams because I wanted to like make a choice of like whether I was getting an epidural or not. And like I was throwing up and I was still 2 centimeters. But she said like my cervix was stuck, and she held it for a contraction. And I went from 2 to 5, like in one contraction. And then I labored for like, I was like, maybe I want an epidural. And I'm like, no, I can do this. I labored for like 7 more hours. I asked to get checked. I was 2 centimeters. They had like set up the table because I looked like I was in transition. I was shaking. I was throwing up. The baby, she was asynclitic and sunny side up and just, that makes it so much tougher when the baby's not in a good position. And we were in the tub. My doula had me in like every single position. We were on the toilet in the tub, like doing lunges, like everything. Ended up getting the epidural, then like pushed her out an hour or two after the epidural. So, but what had happened was she was having decels, which fetal heart tones is the #2 reason for C-sections and hospitals. There's so many variations of normal, but I know for a fact, like if my midwife wasn't there advocating for me, then I would have ended up in a C-section if I wasn't with the provider I was with. Because the nurse came in during it and was like, why aren't you prepping her for a C-section? And my midwife's like, she's pushing her out right now. Like, because she was actually having like a super hard time recovering. There was meconium present, which obviously becomes like a diagnosis. But she did end up in the NICU for a week. She had aspirated, and her lungs were filled with fluid. And so, yeah, I think his nervousness comes from not having an uneventful birth. Like our first, we were in a hospital, baby in the NICU for a week. Second birth, birthing center, I had a significant hemorrhage, which they managed fine. I felt fine. I had like 0 symptoms of it. I didn't have low blood pressure. I wasn't lightheaded. I felt they were like telling me I'm hemorrhaging, and I'm like, I feel great. So, but because it's a birth center, they do have certain rules that they have to follow. So my midwife's like, hey, listen, if you go over this point, we have to transfer you. Like, you know, and then our third came out stunned. She was saying, she wasn't worried about his oxygen because we left the cord intact until I birthed it. But he was just having a really hard time. And then he started retracting and we ended up in a NICU transfer. So, and he was only there for a day and we got to go home. But to him, he's like, we haven't had any uneventful birth. And that's what I think is a huge part of your hesitation.
Yeah, well, for sure. Well, even like with our first, right? Like if the heart rate isn't recovering, in my mind, I'm like, okay, how much time do we have between right now and this is a real problem? And I think that's my concern with home birth because in the hospital, they're there. If there's an emergency, they're there. In the birthing center, it was like a 5-minute transfer, if that. They had it down to a science. They had a hospital they like teamed up with basically. And so I was comfortable with the emergency transfer process. When it comes to home birth, we, it's not like you have a hospital that you are teamed up with. It's not like you have they run tests every week or whatever it is. So my thing is like, okay, let's say the same thing that happens with our first happens again. How are we, and I guess this might just be like the midwife we choose, but like, how much time do you have in a situation like that where like the baby doesn't become affected from whatever, not recovering well, the heart rate not recovering well? Like what's the timeline, I guess?
I can't really answer that because it's so dependent on a particular scenario and um it's hard to pull apart what would have happened at home with exactly that baby and that birth and then what was happening inside of a medical facility with that baby and that birth with some interventions.
Mm.
So it's you can't quite pick it apart that way.
Hmm.
You you really your security or potentially your security is understanding the risks, understanding the percentage of those risks if that's an important part of how you make decisions, talking to your midwife about how they're going to respond if a scenario like that comes up. And feeling comfortable with that plan, really, right?
Yeah.
Because mean, sometimes we serve people who are an hour and a half away from a hospital, and that needs to be a part of the discussion of
Right.
like, okay, well, if we need medical care, we have to activate that sooner than we would normally if we were 10 minutes
Yeah.
from a hospital, right? So that is a very individualized conversation, and
Sure.
what your midwife feels comfortable with, and ultimately what you feel comfortable with. I mean, we've been in scenarios where women have asked for more hands-on than what we normally defer to. And we have to talk through that. Like, okay, truly, if that's what you want, we can be more hands-on in that way because we want to provide a service that is going to meet your needs and your desires. But let's pull that apart a little bit. Why do you want that? What is it that you're afraid of? What are the chances of those things actually occurring? If we don't do something ahead of time, more active management, how can we react in the moment once that's happening? Um, so there's lots of different ways to managing potential complications too. And it kind of comes down to the provider, their preferences, their philosophy, the client's preferences.
Hmm.
Um, so I think all those things really have to get talked out with the individual midwife, because I
Yeah.
can't tell you how much time your baby has, truly. I mean, it depends how compromised that baby is, and where is
Hmm.
there another event that happened earlier in the labor that we don't know about, and now your baby is in its second emergency event.
Yeah. So in
Yeah.
the case of the aspiration and the meconium,
Mhm.
that is something that you would be like, okay, this is a transfer. Like we need
Yep.
to, yeah, okay.
Yeah,
Um,
but in that case, it's unlikely that it would be a fast emergency that needs to be
Right.
yeah,
responded to.
no, it wasn't. Even
Yeah,
then, they were like, she was having trouble breathing. I could see it. They were like, you know what? Just give her to mom, let her get warmed up, whatever. And then they took her back and they're like, you know what? We're just gonna bring her to the NICU just because something looks not normal. It wasn't an emergency by any means,
yeah,
but
yeah.
it was right down the hall, you know? Um, but I think that leads me to probably my last question. But what are, because you're lovely and you're in California, so this is nothing to us, what is something that you think we should be looking for when we are interviewing a midwife? What are like red flags in a
Yeah.
mid, because obviously, just like in any profession, there are good concrete guys and there are bad concrete guys. There are good cops and bad cops. There are great midwives and there are bad midwives. Like, what are something that we should be looking for in a positive way and stuff that we should be looking for where it's like, hey, this is probably not a good midwife.
Yeah, I mean, probably most of the midwives in your area are all going to offer somewhat of the same level of service. So don't get distracted with where their office is located, how closely they work with insurance, if they give discounts for certain things, if their appointments are longer. I mean, all of that is fine, but probably on paper, the midwives are all going to look the same.
Hmm.
Meeting in person, I think, is really important, and your mutual gut feeling about them, I think, is really important too. And I kind of touched on this earlier, but um, walking into that appointment, knowing, or into that interview process, knowing that it goes both ways, that you don't want her to work with you unless she feels excited to serve you guys too, and that it feels
Okay.
like, oh, okay, we're going to be like a team. So you can ask her questions like, who's your ideal client? And tell me about a time that you had a really challenging birth scenario, and how did you respond to that? Or what's your philosophy about the use of medications and the equipment that you bring? Like, how often do you use that? Um, what I can do is we have a list of questions that women should ask in the interview process, and I can give that
Mhm.
to you guys, and you can also give that to your listeners too, if you'd like,
That's a great, yeah.
because there's quite there's quite a few questions that kind of help to like uncover some of the meatier pieces. But I think a gut instinct on it, and you guys both mutually agreeing on that, you and Liz, but also feeling like the midwife is excited to work with you guys too is an important part, because ultimately I think that, and I said this already, but it's so true. The thing that is going to keep you feeling confident and like your wife is in good hands and like you can sort of relax and try to enjoy the
Hmm.
process, or be present for it and not thinking like, hey, is everyone doing their job here? Um, is trust and relationship, and you going to as many prenatal appointments as possible and being a part of the care and having space to ask
You're laughing.
the question.
Yeah.
He works
Sorry,
a
I'm
ton.
just no, I'm
Is
thinking
that
about
why?
I'm thinking about all the ones I've been to where
Oh my
they're like,
gosh.
okay, Vito, like it's been 2 hours. Like
Yeah, for real.
I gotta go.
For real. I remember it was our first at the birthing center, and he asked so many questions, and they were finally like, listen, we gotta see other people.
They were great. And I didn't take any offense to it. I didn't take it like they were rushing me. Like they were awesome. But
And they
I
usually
was
like
just
check
laughing.
his blood pressure too, because he's such like a stress case. They're like, Vito, you
I'm
should.
not a stress case.
You get nervous. You
Yeah,
just get nervous. We've had
it's a
some traumatic
very,
stuff that has
yeah, it's a
happened,
high
and
emotional experience.
yeah,
So
yeah.
no, that's great. No, if you could send me, I mean, I personally would like to see those questions. I think that's great.
Yeah.
And then yeah, it makes sense, just kind of feel it out. And I think that's what it was with the one we interviewed. I didn't feel like she was excited. I think that's what it was. Because
Well,
just when you mentioned that, I was like, I think that's what it was.
I think part of it too, I mean, it was over Zoom because it was COVID, and I think my biggest fear, so at the time, the reason I remembered why I said no to a home birth the first time. At the time, I was employed by a hospital. I was working with a midwife group at a hospital here. And so I knew the midwives, trusted them, worked with the nurses. And my biggest fear was, I know one of the number one reasons that transfer rates are higher in first time moms is like epidurals. They want an epidural. And it's like almost a third, right, of first time moms end up transferring. And it's usually for like pain relief. The hospital that I would transfer to by us, I do not want to give birth at. I do not want to birth there, especially for a first time. And I just know how even that would be a concern now. Like if I got to like 42 weeks and I birthed at home, then we end up transferring, they would treat me like I'm an alien. Like, you're 42 weeks, you're trying to birth at home. Like there's no respect for birthing outside the system. And it just wasn't a place I wanted to be at. So I'm like, you know what? I know the midwives at this hospital. I know they have birthing tubs. They were doing water births at the time. I had doula there. Along these midwives, I'd seen so many unmedicated births, like almost all of them. And it was great. So I'm like, I'd rather just be with people that I know and I trust, and I don't have to like transfer in case I want pain relief or whatever. And yeah, I ended up getting the epidural with the first one, but that's why I ended up making the choice. But after we had the first, I was like, all right, I've been through it. Like, we can home birth all the way. Don't give me that face.
Okay. Is it normal for midwives to give referrals for like if I'm interviewing you, let's say, and I'm like, okay, everything is great, we hit it off, our philosophies line up. Can you give me like three people numbers you've worked with in the past and I can talk to them? That's
Absolutely.
normal? Okay. Because
Absolutely. Yeah.
I'd want to, I just don't know like
Well, and
what's normal on it.
like for you, Vito, I would especially say, like, are there dads that are willing to talk to me about their experience?
Yeah.
And like if we were interviewing with each other right now, I would say, Vito, let me ask permission if I can get you some numbers for guys who weren't sure about how this was going to go.
Hmm.
Initially, we're having some trouble getting on board, and then you can hear their story about how that turned out okay for them. Because dads are the number one cheerleaders of home birth.
Hmm.
Moms are like, yeah, I know that was wonderful. It's exactly why we decided to do this. And dads are usually like, I wasn't sure this was going to be okay. Actually turned out really great. So from their expectation to how it actually happened, they transform so quickly that they're just like, everyone needs to know about this.
Yeah.
I was the doubter once, and now I see, like, my wife is so comfortable. We're all at home together. The kids could be a part of it if they wanted to. I'm sleeping in my own bed tonight. No one's driving in the car anywhere. And
Mhm.
right, there's a lot of logistic pieces that are really friendly for dads. But I'd give you the numbers of dads who were like, yeah, I was like not really sure about
Yeah.
this because then they understand where you're coming from and you can talk to them. But there's probably lots of community places for you guys to connect just in your hometown, right? I mean, Liz, you're
Yeah.
probably connected to a lot of, weird birth people that that Vito
Yeah.
can talk to, right?
I'm gonna try to convince our last midwife to do it at home
Mhm.
and bake her some cookies or something.
You might have to bake her more than that.
For sure. Cookies
That's
all
so
the
funny.
way.
Yeah.
So, and then sorry, I just popped in my head. You're also trained in monitoring the baby once they're out too,
Yep.
correct? And then you
Yeah.
do like postnatal visits,
Mhm.
all that stuff as well.
Yeah, so we're licensed to care for the normal newborn for 6 weeks postpartum. So
Cool.
our moms don't even need to go see a pediatrician for well baby care. If they don't want to, I mean, they're welcome to, of course. But yeah, we continue to monitor mom and baby, and we do all of those visits in their home, which is just cool. Nobody
Cool.
has to leave to go
Right.
do.
And then
And
maybe just some like from a man's perspective, logistical questions. Do midwives, they only work off cash? Do you do insurance? Do you do credit cards? Like, it's got to be cheaper than our hospital bill was like $50,000. So, I mean, and then I think our midwife was 8 with all the
Yeah.
appointments.
Hmm.
But as far as like home birth, how does that work financially? Like, do you take, what do you take?
We take all forms of payment pretty much, and some midwives will even barter. So that's worth, women asking for if they're in a financial position that they can't afford a midwife's fee. They should look at can they barter some service or barter something with them, or exchange something because a lot of
Mhm.
midwives go into that. A lot of midwives give payment plans. Like we allow our clients to pay us for 6 months, up to 6 months after the baby's born. And so that really helps to spread those payments out to make it more affordable. We do
Mhm.
give a discount for cash. We give a discount for paying early. Most of our clients take advantage of that, but we take credit cards, we take health insurance, or we take health savings accounts.
Okay.
Um, if your employer pays into that, or if you pay into that with your employer, providing the benefit. And our practice works with insurance. We have a biller who's like a totally separate thing that we just work, she works as a third party to get reimbursement for our clients whose plans support it. And so that's always worth looking into, even if it just moves stuff towards your deductible.
Mhm.
Sometimes that's worth filing a claim for. About, I don't know, I would say 50% of our clients get some good portion of the birth covered, like maybe $2,000 or $3,000 worth, depending on their insurance plan. And all of those things can be found out ahead of time. You can get your estimate of benefits,
Yeah.
before you even start working with a midwife, so you can kind of know what that's going to look like. Um, but we tell all of our clients be prepared to pay out of pocket for our services and then be delightfully surprised if you get reimbursed. So go in with the mindset that you're going to
Yeah.
pay for it all, that it's a priority to your finances, and that you're willing to do it. And we'll settle that up one-on-one. And then if there's some kind of reimbursement that can happen at the back end, then we'll just be so happy that you got some of that money back.
Yeah.
Somebody's doing fireworks or something
Yeah.
right now. Did you hear that on your end?
Oh,
Oh, um, yeah, because I know when we had looked in over here, I think the person that we were talking to, we wasn't taking insurance at the
No,
time.
no.
So, but yeah, I think that that's another thing where I'm just like so passionate. I'm like, man, I wish on a higher level in this country that they would just make midwifery care more available to women, more options of insurance covering it, of the reimbursement of, whatever it is, like providing, getting more people licensed if that's like what it needs in areas where there aren't any around. And I'm like, man, I just wish that women everywhere had all of these options.
it only makes sense that you would be sent to a midwife to give birth. Like it never really made sense to me that you'd be sent to an OB.
Right. Well, that's like our midwife, Sarah, I interviewed her on her before, and she was explaining the midwifery model of care, and she talked about how like midwifery care should be the entry level care for everyone. And then if you risk out, but I think the problem is too, a lot of people think, well, I am high risk because I'm over 35, or because I have a higher BMI, or because of gestational diabetes. And it's like, well, that doesn't necessarily risk you out of midwifery care. That's just a risk factor. But if you are in a hospital setting, you are going to be treated high risk, with these different factors,
Yeah.
even when you're not.
Yeah, you're in a high risk setting, and your providers are they're way better at high risk than normal low risk. So you have to really look at that, like how the setting is set up to respond in an emergency, and everybody's waiting for that emergency to happen. And your
Yeah.
provider's trained in handling complications and looking to use their tools and expertise. When your tools and expertise are to trust birth, to communicate well with your client, to not do stuff even if you want to, kind of sit on your hands a little bit, to just observe and wait. It seems like it's kind of passive qualities, but that's what keeps birth safe. That's what keeps
Yeah.
things from getting messed with, right? Is that perspective.
Mm-hmm. Yeah. Yeah. Well, send me over those questions. I can include it in the show notes. And for everybody listening, I'll include links to where you can find and follow. Tiffany works with Beautiful One Midwifery, and that's like how I followed her online. I follow their Instagram, and you guys post so much great information. And I know I'm always like reposting stuff that you guys put out because I'm always trying to educate people. It's all I talk about. So I will include all of the links in the show notes. So I just want to thank you so much for your time and energy and expertise, and for coming on the podcast and letting Vito ask you all of the questions.
For what it's worth, I would be honored if you were our midwife.
Oh, that's so nice.
She's very confident. I look for qualities of like leadership. You definitely are you present yourself as a leader, as an expert, as someone who's not afraid to be like, this is a time to transfer. You don't seem like you have an ego involved in being a midwife or doing something that's, unordinary. So I definitely, I don't know you that well, but I respect you, and I think that I'm sure you're a great midwife.
Oh, thanks, Vito.
Why are you laughing?
Because you're like, you only want people to be our home birth midwives who don't live here, who won't do home birth. And it's like, now we gotta find one here.
And you will, and you're gonna go on interviews with other home birth midwives, and you're gonna ask them the questions that you asked me. This was like a little like we got to play it out a little bit, Vito. And so now you get to go and replicate that in other interviews and ask the same questions. And now you have a standard of where you expect the midwife to respond to. And then you can use this little interview as a way to kind of like gauge your feelings of confidence and comfortability with somebody else. And so I hope that some of the listeners got a piece of that too, that they got a little bit of confidence, a little curiosity, a little bit, that it feels more accessible. The idea feels more accessible.
Yeah. Awesome. Well, thank you again so much for coming on.
Thank you for having me. It was so fun, guys.
Thank you.